Thank you. Case-based clinical rounds. I think I recognize everyone in here, and everyone should recognize me and Dr. Gibson. So we'll just dive into a case here. 87-year-old Italian female comes in with a 2-hour history of shortness of breath, intermittent stridor as per EMS. That's all the history you're really given, and that's from EMS. She speaks only Italian, and the more questions you ask her, she'll smile and nod politely. She has a past medical history of congestive heart failure with moderate aortic stenosis, hypertension, atrial fibrillation, had a right mastectomy for breast cancer years ago, depression, anxiety, recent prolonged admission for urosepsis, and an esophageal dilatation in 2012. She's on appropriate meds for these things, including warfarin. When you examine her, because you can't ask her many questions, she's a bit lethargic. GCS is 14, 15. She's in no apparent distress and very polite. She has intermittent stridor with moderate accessory muscle use. She's very calm when she's not having stridor, breathing normally. But when she's having her stridor, you notice some accessory muscle use, and she's a little more anxious. There's no palpable neck masses, however. There are some mild bibasilar crackles, but she's got good air entry. Her oral cavity appears normal with a normal oropharynx. She's got dentures, and they're well-fitting. Her airway assessment is otherwise normal. She does have a 3 out of 6 systolic ejection murmur at the right sternal border. There's no radiation to the carotids. She has mild peripheral edema. Her abdomen soft, non-tender, and non-distender. So I'm concerned about this stridor when she comes in. We sweep her into trauma. So what could be causing this? What could be causing stridor in general? Maybe we'll just start with infectious causes. Maybe I'll ask BA. Infectious causes in general of stridor?
Sometimes that, not infectious, but sometimes with bronchitis, I guess you could.
Bronchitis, sure. What about half the cases that come into?
Not really.
Bronchitis gives you wheeze, right?
Yeah, it's a bit more lower airway. What about half the cases that come into peds emerge?
Croup, yeah.
Kids, yeah. And then, what are you thinking about with a differential when you see a kid with croup?
Stridor or croup?
Stridor in general,
like
but
epiglottitis.
Epiglottitis. Bacterial tracheitis.
Peritonsillar abscess or retroperitoneal.
Peritonsillar abscess, sure. That's, you guys are killing it. The other things I came up with was diphtheria, essentially. What about inflammatory causes? I can throw that out to the group as well. Anaphylaxis, sure. Yeah. 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 And then exposure-related caustic or heat inhalations. Neoplastic. I don't expect you to, I didn't list any specific tumors. Tumors around the trachea, larynx, pharynx, or esophagus. And then mechanical obstruction.
Foreign body.
What things can obstruct? Foreign body in the
Larynx.
in the larynx.
Esophageal, foreign body.
Yeah.
Expressing.
Yeah.
Laryngeal malation.
Laryngeal malation. Nice.
Cord paralysis.
Vocal, yeah. Vocal cord, so bilateral vocal cord paralysis. Yeah. Yeah. Someone who's previously been intubated. Subglottic stenosis. Nice. And then some random other ones, subglottic hemangioma. I don't know, she's on warfarin. Could there be a subglottic hematoma? Or you can get paratracheal compression with lymph nodes or even the thyroid gland. So what should our initial management be for this lady? Kind of scary. Lipkiss? Oh, sorry.
We're pretty quiet over there.
Oh, they're quiet over there. POS. How would you initially manage this lady?
Well, it always comes back to the ABCs, right? So you have her in a resuscitation room.
Yeah.
You're going to be thinking about her airway. I don't know what, she's in some moderate respiratory distress, it sounds like. You're going to get 2 large bore IVs. You're going to apply oxygen. What did, it doesn't sound at this point like she needs immediate airway management, but stridor is always a concerning symptom. So I'd be wanting to monitor her very closely and see what the progression of this is, and consider earlier rather than later RSI, but not at this. Not
So anything else you'd want to have ready?
Well, all of my intubation equipment, surgical airway stuff ready as well, because if there is a mass, this isn't going to be an easy intubation. I don't know what's causing her stridor at this point.
Yeah, that's perfect. That's perfect. Clark, what investigations would you want to do for this lady?
Well, if she's able to go for a chest X-ray, a portable chest might be easier. Yeah, portable chest, and can they do portable soft tissue of the neck? That might be helpful as well.
Yeah, they can.
EKG, and then you'd end up ordering most of the blood work that would come in the cardiac panel.
Sure.
So
Yeah, I think that's entirely reasonable. I think you guys did a great job. So here's what we did. So airway setup. Patient was shipped into trauma at Vic, prepared for endotracheal and surgical airway. BiPAP was applied. Given the aortic stenosis, she had some crackles at the bases and some peripheral edema. Got to make sure it's not a CHF picture on top of whatever else is going on. We ordered an ECG and a portable chest, and did some blood work. So blood work starts to roll back. So a little bit increased PCO2, but not acidotic. INR is appropriate when she's on warfarin at 2.4. Anyone else see anything concerning with that? I didn't. Good, not alone. And you get your portable chest X-ray. I didn't actually. She was a bit tachypnic when she was stridorous, but quite comfortable. Respirate of about 18. She was satting well on room air, but initially had some nasal prongs for comfort. She was afebrile, and again, she was a bit tachycardic around 110 when she was stridorous, but came down into the 90s when not.
Was she stridorous? I mean, is she like?
When she came in, she was about 50-50. It would last about 30 seconds and be gone for 30 seconds, but it was variable anywhere from 10 seconds to a minute. Dr. Shepard, yeah.
Different that she was doing? Like, weird that it would come and go. Was it positional at all? Was she in one position?
Yeah, we thought there may be some positional component to it, but couldn't put her reliably in one position that would keep it at bay, unfortunately.
Was she lying down?
She was sitting up. She was sitting up, yeah.
Oxygenating in general, and then when she was
In general,
stridulous, was that affecting her oxygenation?
Yeah. So she was satting well on room air, and her sats would kind of dip down into the high 80s when she was having these stridorous episodes, but would spontaneously go up to normal afterward. Yeah. So
Maybe just get a thought of what you
yeah.
think of.
Yeah. So what are we thinking at this point? And Muchacho, what are you thinking?
So with the chest X-ray or just in general?
Just in
with this
general.
lady?
Where are we at?
So we were a bit concerning with the stridor. We've resolved a bit with BiPAP. Looking at the chest X-ray, it's not a great picture because she's kind of slumped over, chin's over it a bit. Not a great inspiration, but maybe she's not capable of that right now. Consider looking at the mediastinum as well in this. So it's a portable, so you're going to have some magnification, but there's just a lot of opacity there, and it looks a bit widened with the right heart border a bit obscured, as well as the left heart border with something there blocking the left postophrenic angle as well.
Yeah.
Sitting that way. So maybe be concerned: is there a mass there? Does she have a big aneurysm? Does she have something that's causing that internally in her chest?
I agree, and there is some degree of magnification. This was actually read as a normal chest X-ray. They didn't even catch that old broken shoulder that I looked at initially. At this point, she's starting to maintain very well. You know, there's no clear evidence of CHF, and she was taken off BiPAP to test her back on room air, and she was doing better. She seemed to find some positions that she wasn't stridorous in, and we kept an eye on her for some time. She was able to maintain lots of different positions. We didn't try to lie her down or anything like that. Where she wasn't stridorous, and she looked quite well, was maintaining her SATs. So at this point, we actually felt comfortable sending her for CT, given the fact that we had no idea what could be going on based on the limited history we were given. Would anyone else send her for CT at this point?
Lie flat to have a CT?
She was able to lie flat. Yeah, yeah. Yeah. Yeah, yeah. Yeah, so just back on the physical exam, normal oropharynx.
The lateral X-ray, X-ray.
So they generally they don't do a lateral with the
They can portable. You can get
with the
that.
portable. Yeah. Yeah. That didn't get
They
done.
didn't use my trusty mirror.
Yeah, yeah. Chris.
Say when she was on BiPAP, she had no stridor, like that made the
It
stridor
completely resolved on BiPAP. Yeah, yeah. Does that give you any?
about obstruction, something mechanical. I don't know what, but something mechanical maybe is being splinted.
Sure.
Open in the airway with the pus.
Sure. We felt comfortable sending for CT at this point.
Given to just going, getting ENT to come and scope her?
Yeah, it's certainly a thought, especially where
Is there any consideration?
we didn't. I think that there was a bit of red herring in early on in assuming that there was some CHF going on with whatever else was going on, but we didn't dive right into an ENT consult at this point. Yeah, so definitely another thought. She went for CT. I don't know if anyone wants to comment or anything on what it shows. A select axial and sagittal cut. Pick somebody. All right. Jake, you see anything on the CT?
On the axial cut, it looks like there's a retrolaryngeal mass. It's invading the tracheal lumen. And on the lateral,
If you're looking there, in there.
I can't tell, depending on where the cut is, if we're right in the midline, but there's something obstructing the lumen as well.
Sorry?
There's something obstructing the lumen on the lateral as well. But the arrow
The
still
tracheal
helps.
lumen. Yeah. Yeah, so that helps. The green arrow is the esophagus, the blue is the trachea. So you can see that the diameter is quite reduced. And then on the lateral, there's a large food bolus within the esophagus there, and the trachea with the blue arrows. So at that point, we had our diagnosis of esophageal foreign body food bolus. That's the case. So objectives for today, we're going to talk about a little bit about esophageal foreign body obstruction. And really the goals are to develop an evidence-based approach to esophageal foreign body management. We'll talk about the pharmacologic as well as the non-pharmacologic interventions that we could do. We'll try better to define when's a good time for expert consultation, and we'll review indications for advanced imaging in esophageal foreign bodies. So, you know, the most important textbook I have at my house, I had to review to make sure that I have a good approach. And of course, that's the New Warren's Household Physician of 1897. It's a great read. So I reviewed the chapter of foreign substances in the gullet. And if the substance have not gone beyond the reach of the thumb and finger, thrust them down as far as possible and try to pull it out. Or a small curved pair of forceps will reach lower still than the fingers. Or, this failing, let someone place one hand firmly on the chest of the choking person and give him a smart blow or two between the shoulders with the other hand. If the substance be down some way in the gullet, it may be pushed along into the stomach by some smooth, blunt instrument. And I think that's great. That's kind of the approach we still use today. They already knew it 120 years ago, and I'm presenting it for grand rounds. But it's good to have an approach because you never know what you're going to find, whether it be a fish hook, SpongeBob, those scissors that just didn't make it down, or this was probably from a Canadian paper, a skate charm. So just a little bit of background on esophageal foreign bodies. The true incidence is unknown. A lot of people suffer from these and they'll eventually pass and they don't present for medical management. We know that at least 75% of these foreign bodies occur in children 18 to 48 months, and the bulk of these are coin ingestions. And that 75% of foreign bodies in adults are food. 63% overall are meat. These are usually at the lower esophageal sphincter. Other risk factors for an esophageal foreign body are really the risk factors that lead to foreign bodies going down the esophagus. So pre-existing dysmotility, certainly, and then psychiatric comorbidity for obvious reasons, drug smugglers for obvious reasons. Being edentulous puts you at risk for a few different reasons. One, if your teeth aren't in, you're not chewing things as well. Two, you lack that sensation feedback that you've chewed things well enough. And the third is if you have poorly fitting dentures or dentures that break, people are actually at risk of swallowing those as well. There are approximately 1,500 deaths worldwide. The Canadian data on that is much more scarce. And serious complications include esophageal perforation, abscess, pneumothorax, pneumomediastinum and mediastinitis. Vascular injuries can occur as it extravasates and cause aortoesophageal fistula, and tracheoesophageal fistula is a concern as well. So important not to let these linger. So back to our approach, to push or to pull? That is the question. So what can we push safely? A small blunt object that's likely to pass through the digestive tract without injury, and something that's located below the upper esophageal sphincter that you don't think you can safely, directly visualize and remove. What are we definitely going to pull? Sharp objects we don't want going through the digestive tract. Long objects more than 6 centimeters are not going to make it by the curvature of the duodenum. And really, objects with a cross-section of 2 by 2 centimeters are unlikely to pass by the pylorus. Batteries and magnets are of special concern and should always be pulled when possible. And of course, as we said, if it's retrievable within the pharynx, it's better for the patient to do so. So what options do we have? So certainly endoscopy, flexible or rigid, is the gold standard, but it's also time and cost prohibitive. So what can we do down in the emergency department? Options are effervescence, glucagon, nitro, and proteolytic enzymes, and pushing with the bougie as well. Options for pulling are direct or video laryngoscopy for pharyngeal foreign bodies, as well as a Foley catheter technique that we'll talk about. So effervescence. So the mechanism of effervescence is to produce carbon dioxide within the esophagus that slowly dilates the esophagus and hopefully the lower esophageal sphincter. Classically, soda water and Coca-Cola has been tried, and there are cases within the literature that they've used those things. In our emerge, we have easy gas granules that contain sodium bicarb and citric acid that combine in water to make carbon dioxide. Is there any evidence for this? Well, the best is basically a conglomeration of case reports and case series that looked at 62 patients and found a success rate of 80% overall without any other management required. 3% of these patients had complications as simple as vomiting, and aspiration to, there was 1 esophageal tear. The cost is around $2. Whereas glucagon, the cost is about $52. It's $52.50 on our formulary. The proposed mechanism of glucagon is decreasing lower esophageal sphincter tone and smooth muscle relaxation. Does it work for that cost? Does it work 25 times better? The best evidence we have is a double-blind RCT that included 14 patients, all of which were pediatric patients, all of which were coins. So not necessarily the group that we think about using it in necessarily. And they found no evidence to support glucagon, and there was a trend towards worse outcomes when glucagon was used. A couple of recent papers within the last year. The first was a retrospective review in 2016, kind of on the pro side of using glucagon. They retrospectively reviewed 440 of their patients that received glucagon either alone, with nitro, or with a benzodiazepine, and overall they found 39% success rate with the glucagon. That went up to as high as 45% when benzodiazepine was added. On the downside, vomiting was shown in 12.6% of these patients, and that was not considered to be in the success group. On the downside, they didn't compare it to a control group that, we don't know how many of these esophageal bodies would have passed on their own. There's another recent paper with a decent amount of patients, 127, which stayed on the anti side of using glucagon. Another retrospective review that found a 14% success rate. They did use a comparator control group and found 10% of people within an hour passed the esophageal foreign body without glucagon. And again, found 12% of their patients vomited as well. So they did not support the routine use of glucagon. Where does the American Society for Gastrointestinal Endoscopy stand? Essentially, they state in their guidelines that glucagon is relatively safe and thus remains a acceptable option. What about nitro? We use it for esophageal spasm and things all the time. There are 2 reports of use and benefit. These are 2 letters to the editor of Annals in 1980, so not routinely recommended or studied. However, it is on Life in the Fast Lane as a viable option. Proteolytic enzymes have fallen out of favor. 4 concerning case reports in the past, one of aspiration pneumonitis, one of hemorrhagic pulmonary edema, and 2 of esophageal rupture. And the physiology makes sense. You're giving proteolytic enzymes and your esophagus is made of proteins. So it was sort of abandoned at that point. Not to be outdone, a group of thoracic surgeons at Harvard have still been using it, and they reviewed retrospectively 69 of their patients that they still given this papain or papaya extract. That's a proteolytic enzyme, and found that no one out of these 69 patients had any adverse events, and they had a success rate of 87% of distal esophageal food boluses being passed. Now, the caveat to that is the mean time for passage was 180 minutes with a range of anywhere from 20 minutes to 48 hours, so not essentially that practical in eMERGE. But they argue that there was some decently wide usage of this in the past, and based on a small amount of case reports, it's been abandoned. So they open it up as maybe this is still a viable option. But here comes the big American Society for Gastrointestinal Endoscopy, who puts their foot down and says proteolytic enzymes like papain should never be used in no uncertain terms. What about the bougie? We love the bougie. It's well described in the pediatric literature, specifically for coins. There's multiple studies showing its safety and its efficacy, but it's not described in adults. Theoretically, if a large coin was stuck in the upper esophageal sphincter of an adult, it could be attempted, but theoretically a distal food bolus, which is the most common by far, would just be macerated by a bougie and not pass through the sphincter. Another thought is Foley catheter removal. The best evidence for this comes out of Kansas City, where they looked at 500 patients. Now their technique for this is to have their general surgery resident go to the fluoro suite with an emerge nurse, and under fluoroscopy, they pass a Foley catheter past the foreign body, inflate a balloon, and pull out. With these 500 patients, there's an 80% success rate and 8% of passage into the stomach, which if it was acceptable to go into the stomach, they added to the success, giving it an 88% success rate. And there were two, because they were using it, they were actually using it intranasally, they had two episodes of epistaxis where there are only negative outcomes. Then there's our gold standard, that's endoscopy. There's flexible, which at our center is gastroenterology, and there's rigid, which ENT usually performs under a general anesthetic. Who should we call? Basically anything that could reasonably be pushed, you should give the gastroenterologist a call. Recent paper showing that flexible and rigid endoscopy had similar outcomes whether you were pushing or pulling, and there were no severe complications in flexible endoscopy, whereas in rigid endoscopy there were 2 cases out of 63 with esophageal rupture, and that's well known that the rigid endoscopy comes with more risk. When would you consider calling ENT? If you have a complex or sharp foreign body, or any time that you're worried that this could progress to being a surgical issue. And talking with representative from both parties, they think that's a reasonable approach. When in doubt, call gastroenterology first, and they'll see if they can do it with a less risk and better tolerated flexible endoscopy. In terms of timeline, how hard should we be pushing these consulting services to come down? This is based on the European guidelines. Emergent cases, so sharp foreign bodies and other things that you're concerned about that aren't acutely perforated or have mediastinitis or pneumomediastinum, 2 to 6 hours they quote as generally reasonable. 2 hours is ideal, but up to 6 hours is okay. And urgent things such as food boluses that aren't passing, or coins that can't be retrieved by conservative means can actually wait up to 24 hours, and that improves their rate of spontaneous passage. So back to our case. Of course, the family arrives right as we finish the CT, and they say, "Oh yeah, now that you think of it, she's had some pain after eating, some recent dysphagia, and it was right after supper that she started to have this stridor." Might have pointed us in a different way. As we mentioned, the BiPAP was removed, and with positioning, she was able to remain stridor-free. She was on nasal prong O2 just for comfort. GI was consulted, and after coming down, looking at her, she was having no more stridor. They actually said, okay, despite the fact that she was stridorous when she came in, we'll see her in the morning and scope her tomorrow. And based on that 24-hour mark, it was hard to argue. They did their endoscopy and found a tortuous dilated esophagus, but no food bolus there. Some scarring to suggest some previous esophagitis, and they performed a dilatation at that point and discharged her home later that day. So another quick case, a 71-year-old Greek female. I'm having trouble with European senior citizens. 1 hour foreign body sensation in the posterior pharynx. This is 1 hour after she was having fish for dinner. Concerned that there was a bone caught. There was a few bones in the fish she was eating. She was otherwise well. Past medical history was non-contributory. No physical findings or vitals, all within normal limits. Just concerned about this fish bone that may or may not be stuck in the back of her throat. So what's our workup for this? I think Dr. Gibson was hoping that Dr. Pringle was here. So apparently an inside joke. The fishbone is theoretically radiopaque. So who would do, based on this posterior pharyngeal foreign body sensation, who would do an x-ray? Staff or residents? Yeah, a few hands, lots of hands slowly going up, yeah. Would anyone go to CT if that x-ray was negative? Maybe one, okay. Would anyone try to put the ultrasound on and try to find it? No, not even Dr. Hames would do that. Okay, what if it was in the esophagus? Or Dr. What if it was in the esophagus? X-ray, reasonable? Yeah, I think everyone would agree. If the X-ray was negative, would anybody be rushing to CT to try to find the fishbone in the esophagus? No? Okay. Anybody, no ultrasound takers for esophagus? Well, it has been described. A recent paper from this year. There's 2 case reports where it was found. It was confirmed on X-ray, and I don't think this is something you need to jump to, but it is described. There it is. These were coins, actually. These were coins in children. So just the technique itself has been described to ultrasound esophageal foreign body. I think a fishbone might be a little harder to detect than a big old coin, and I think an X-ray would be reasonable in these kids anyway. But just to say that it has been described. X-ray is pretty standard, either for esophageal symptoms or pharyngeal. The bulk of people said, whether for pharyngeal symptoms or for esophageal symptoms, that a negative X-ray, maybe a negative look in the oropharynx, means you're okay. You should be able to go home, be just fine. But remember the big scary complications we talked about with esophageal perforation, potential abscess, potential aorto and enteric fistula, and things like that. The stakes aren't zero of sending somebody home without knowing for sure. And there was a study, and actually multiple studies now in the past couple of years have come out of China and Korea, where there's lots of fishbone foreign body ingestions because it's such an integral part of their diets. And basically it showed that the sensitivity of a single X-ray to detect a fishbone was about 45% when compared to CT. The sensitivity compared to endoscopy of CT was anywhere from 97 to 100%. So X-ray maybe not as good as we thought to detect these foreign bodies. And this is an example of one with a normal soft tissue neck X-ray that fishbone in the esophagus was ultimately found. Mason, based on the push and pull stuff that we talked about, should that be pushed or pulled?
Well, I don't know how sharp a fishbone is, but I'd be worried that it could penetrate, so I'd pull that.
Yeah. Would you do that yourself?
No.
No? Who would you call?
I would call GI first.
Yeah. I think that's entirely reasonable. Awesome.
Everybody who has a foreign body sensation in their throat should have an X-ray?
I'm suggesting it's an option. This is for esophageal symptoms. I should clarify. This was for esophageal symptoms, whereas the pharyngeal foreign body, we know that it's up to a third of people that have that sensation who will actually have a foreign body, and the scratch that a fishbone or something produces can cause that foreign body sensation. So I think an X-ray or a look, I know not everyone does it, and there's not a lot of literature to suggest that we're missing a lot by not doing X-rays, and I don't think you need to jump to CT for these pharyngeal foreign bodies, but there's some better evidence now that if they're having esophageal symptoms, especially difficulty handling their secretions, that sort of thing, that you think there's some reason they're completely obstructing their esophagus. Yeah.
People who have the sensation of a foreign body in their throat.
Absolutely.
And they're not having difficulty swallowing. there's no stridor,
Mhm.
basically just ate something, and we take a look in the oropharynx and see
Yeah.
nothing.
Yeah.
And so should we x-ray all of those people?
Yeah, I think it'd be reassuring if they have a potentially radiopaque foreign body, such as a fish bone, to do an X-ray, or chicken bone is another one that's often found in the literature.
Effectiveness with a fish bone and actually finding a fish bone.
Mm-hmm.
I mean, there are different types of fish and different types of fish bone. Obviously, there
Absolutely.
are some bones that look like a chicken bone and they
Yeah.
actually came from a fish.
Yeah.
But most fish bones, in my experience, are pretty tiny, pretty
Mhm.
small.
Mhm.
And you do sometimes see them in the oropharynx. But to x-ray them and see them, I don't know. Any
Yeah.
other consultants have a...
I think you'd have to have a higher suspicion, either, you know, if you had that direct look and saw some local swelling, something that potentially obstructive in the oropharynx, then I'd be more inclined to do imaging. Dr. Dagnoni?
We only see it 40% of the time, so we don't see it that well.
Then the question is, what do you do? Do you have to go after it if you see it? Or is this going to be one of those that's going to disappear over the course of 24 hours?
I would argue if it's in the oropharynx and they're reasonable to examine, then you should see it. The problem is, are you missing anything that's completely penetrated and gone deeper? Has completely penetrated the soft tissue and isn't visible within the oropharynx. You'd have to have a higher suspicion
I think those people
to go
are gonna
fishing with
have
that.
worse symptoms.
Yeah.
I guess the thing is, the X-ray is not going to reassure you anyway, so a negative X-ray doesn't improve your prediction of not having foreign body there, so it's really not a
Absolutely.
useful test.
Absolutely.
Yeah.
Dr. Dagnoni, yeah.
Just to reiterate sort of what John and Roy have already said,
Yeah.
like, certainly as a resident and as a junior staff, I would x-ray a lot of these people knowing that I wasn't going to see anything. It doesn't really reassure me. If you see something, you're like, I think most of the time you're not going to see a small fish bone. It's too
Mhm.
small. It
Yeah.
really isn't radiopaque. It's not like a chicken bone or a coin or otherwise.
Yeah.
So you're really relying on symptoms, because we all know after a scratch, it can be 48 hours before they feel better. So it's usually a judgment call. How bad do they look? I don't find
Absolutely.
that an x-ray in a fish case.
Yeah.
I've never, from residency to now, I've never seen a fish bone on x-ray, and I've
Yeah.
probably x-rayed far too many people when we talk to more senior staff.
Yeah,
So I'm
for
not
sure.
x-raying nearly as much as I used to.
For sure. And then the catch being, I would say, based on this study, if I had some reason to x-ray somebody for an oropharyngeal foreign body sensation, knowing this, I wouldn't necessarily be relieved that they didn't have a fish bone that I'm missing with x-ray. So then, you know, in my mind, you're potentially committing yourself to doing a CT if it's negative. So you have to have some threshold to say, I don't think imaging is necessary. Yeah.
CT, like my approach is, if I think they have something that they have a fish bone, plus minus X-ray. If I really think they've got something sitting there, I talked to ENT about scoping, having a look. I must admit I don't CT them, especially for something like a fish bone. So I just get them to come down and scope them, and then they see them.
And I think that's entirely reasonable. I guess you can't reassure yourself. You can't reassure yourself if there's a negative X-ray that that fish bone's not there, based on.
I think you have to remember too that this is two different. You're talking about a hypopharynx fish bone, right? For ENT to come down and have a look and take out maybe. And then this study is looking at esophageal fish bones, so ones that have stuck a little bit farther down that you might not see on X-ray, but would pick up on a CT, and that would be GI coming down to take this, or ENT.
Stoner?
Is there any role in using like a barium study? And I know it's opaque as well.
No, so it's been described, but it's gone completely by the wayside. Nobody recommends it anymore. Nobody studies anymore. You know, the risk being aspiration if you try to put the barium down and there's obstruction, as well as extravasation into space that you may really not want it going into, if that's an issue. Yeah, good question.
Please. In the context of, Lisa and I were just talking, the context of somebody who has symptoms lower down, and you're thinking it's esophageal, and this is just within a few hours, I mean, you're really not doing the x-ray to find the foreign body. You're doing the x-ray to make sure that you don't see gas in the mediastinum.
Yeah.
And those people are going to go home with instructions to come back if this doesn't get better or if your symptoms get worse.
So I guess the argument being made in these studies that if you're doing the X-ray, you don't see any of those sinister findings, and you don't see a fishbone. You know, in the cases that there are a foreign body, we're not seeing that half the time.
Is there a high sense of complications in those patients, like a foreign body, a fishbone in the esophagus under 24 hours? Do you have a sense of like complications?
So these were prospective patients that had that sensation. So ultimately either had a positive X-ray or they had a negative X-ray and got CT'd. And if they had a negative X-ray and CT and still found to have concerning symptoms, they got scoped. So it was known one way or another before these people went home whether or not they had esophageal foreign body.
Conservatively managed though, just like a watch and wait approach? Or no?
In the study, everybody got scoped to make sure that we weren't missing something. Yeah. Dr. Mastasi, yeah?
So for the supraglottic foreign bodies like the fishbones, we also have the Levitan scope in the department, so you can actually look. So I agree with Pico and everyone about the X-rays. I'll X-ray everybody, and I never see anything, or if I do, I don't know what it is.
Yeah. And
then I'll just give them a little xylo to gargle and spray them up and get a direct visualization just down to the cords. If I don't see anything, I'll assume it's a scratch and say if you're still symptomatic in 24, 48 hours, come back.
Yeah. I think that's entirely reasonable. Yeah. So yeah, we're talking, two different cases where we're talking about the oropharyngeal foreign bodies and then the concern for esophageal foreign body. So I thought it was kind of interesting that if we do X-rays, you know, in order to convince ourselves we can send somebody home, we're missing a lot of them that we could be clinically convinced that are there. So back to our case in particular, a negative X-ray and well-tolerated video laryngoscopy and no foreign body was found. So as most of us would do, discharged with conservative management for that oropharyngeal foreign body sensation. So those are the two cases. The take-home points we want to get from that is just to solidify the approach, which we've known for 120 years or more, push or pull, or a stiff blow to the back. That there's good evidence for effervescence. They're cheap, they're available, use them. Glucagon remains controversial even to this day. There's a couple of good studies that have argued for and against even in the past year. Proteolysis is not recommended unless you're a thoracic surgeon at Harvard. Oropharyngeal scratches often mimic a foreign body sensation, as we talked about a fair bit. And an oropharyngeal fishbone should be visible with laryngoscopy, but not always the case if it's completely penetrated. Radiopaque foreign body ingestions, CT has a higher sensitivity than X-ray. If you really want to see it, then CT is the way to go if you have a negative X-ray. Okay, well, let's see if we've learned anything. Anyone tell me what that is?
Battery?
Yeah. So the first two people I asked said, oh, it's a coin. It's a button battery. It's kind of the worst thing to have stuck in your esophagus. You can get pressure necrosis, you can get necrosis because of the acidic and alkali substances that can come out of it. So that needs an urgent consultation, and that needs a pull. Butter knife, should we push or pull? And why? And where? If this didn't perforate, where would it get stuck? Waterman. Yeah. So I mean, there's two diameters that are less than 2 centimeters, so it might get through the pylorus, the end part, but there's no way. It's longer than 6 centimeters. There's no way it's going to get around the loop of the duodenum. But that's unfortunate. This is the most interesting one I came across. Lots of good stuff in there. Yeah. So see whether the residents or staff were paying more attention. What did you see on that x-ray? Bullet, it's not listed as one of the things in there. No bullets.
Keys.
Yeah, there's keys. Nails.
Coins, right?
Coins.
Allen key?
Wasn't specifically one of the things. Yeah. All right. The residents are doing pretty well. So listed in what actually came out was coins, keys, nails, screws, syringes, and somewhere in here there's a spoon. Oh yeah, at the bottom. It's ready to come out. Okay. So that's all I have. Thank you for listening.